Hey there. This is Alison Moe. I am a PA from Atlantic Gastroenterology Associates, a division of United Digestive. Welcome to my GAP MASLD MASH community network. We'll go over some do's and don'ts and some pertinent pearls for metabolic associated like liver disease. And I appreciate you joining me, and we'll do some questions at the end. All right. So MASLD and MetALD, what they mean, what our overlap is, and how we differentiate between the two so we know how to appropriately treat our patients. This is a great patient example, very common with what we see in the office every day. So Ashley is a 52-year-old Caucasian female. She was referred to the office to see you because an abdominal ultrasound showed that she had mild hepatomegaly and increased hepatic echogenicity, which is what we see on many ultrasounds, consistent with steatosis. She otherwise feels fine and has no complaints. What I do think is important to point out is we're at least thankful that we got this referral to begin with. There are many people who just say, "Oh, you just have a little bit of fatty liver, just lose weight and you don't have to worry about it." And now with, obviously MASLD and MASH and MET-ALD, we know that that's not correct, and we want to make sure we capture these patients to try and prevent that fibrosis. So you see Ashley, obviously, for the above, and we do some exam and labs on her. She has medical history that is with polycystic ovarian syndrome, hypertension, and hyperlipidemia. She has, on a physical exam, no evidence of a palpable liver, and she takes amlodipine, atorvastatin, milk thistle, and MVI. Now, up until we get to her social history with her 2 glasses of wine a day on average, this is actually exactly one of our patients that we have with metabolic associated steatotic liver disease. But for her, the fact that we have our social history of 2 glasses of wine a day on average, that patient and that person really needs to be considered for potentially having an alcohol component added into our workup. So we do some labs besides her physical evaluation, and we see her blood pressure is borderline. Otherwise, temperature is fine. She's a little bit overweight. Her liver tests are very classic with what we would see on our patients who have steatotic liver disease. Her AST and ALT are very mildly abnormal, but they are elevated. But the biggest difference in these labs that we don't commonly see in patients who have metabolic associated fatty liver disease and patients who only have or have a conjunction of metabolic with alcoholic liver disease is that alkaline phosphatase. Total bilirubin is slightly elevated. Platelets are normal. Hemoglobin A1C is okay, and triglycerides are okay. So if I saw this patient in the office, that alkaline phosphatase would, and the total bilirubin would make me question if there was more than just metabolic associated fatty liver disease just based on those values, even though I expect the AST and the ALT to be elevated. So just because she socially drinks alcohol doesn't mean that you wouldn't do a fibrosis assessment on her. We may or may not offer her a certain treatment for her advanced fibrosis, but we know we at least need to do that part of the workup. And probably surprising to her and to us, not only does she have an elevated CAP score, the fatty liver part I think was pretty expected, but her kPa or her kilopascal or her fibrosis score is elevated. She is in the significant fibrosis of F3. And I think that for a patient like this with relatively stable, I mean, her liver tests are elevated, but they are not significantly 5 times the upper limit of normal, etc. Her platelets are normal. They're not less than 140 or even close to 140,000. She has significantly advanced fibrosis. So, steatotic liver disease, we know we've got this broad umbrella of steatotic liver disease, but then what are the culprits and what are the things and etiologies that make that happen? I'm going to start on the the right side over here, which is, you know, patients who maybe have drug-induced liver injuries. Have they been on certain medications long term, seizure medications? Potentially even steroid medications or heart medications. These are patients that get steatotic liver disease that are very uncommon for what we see in our office. But here on the middle and left side of the equation are the patients that we see on a regular basis. So these are patients who have metabolic dysfunction associated steatohepatitis, patients who have metabolic associated steatotic liver disease, this patient, which is the metabolic steatotic liver disease and increased alcohol liver disease, which is called MetALD because it's metabolic and alcoholic liver disease. And then the patient that is your non-hypertensive, not high cholesterol, not obese, no diabetes, but just drinks more than the acceptable range of alcohol. And you'll notice here on our patients with the metabolic and alcoholic liver disease, we have a good graph to show us how much weekly and daily alcohol intake means that the patient would be more on the metabolic side or the patient would be more on the steatotic liver side, metabolic side versus the alcohol side. So if I have a patient like this patient who drinks 20 to 30 grams of alcohol in a day, that patient may be more on the metabolic associated side, especially because we know that our patient here has PCOS, hypertension, and obesity, as well as high cholesterol. But if I have a patient who did not have any of those risk factors, and I was questioning whether or not maybe just their central weight was what was contributing to their metabolic associated liver disease, but they drink more like 3 or 4 glasses of wine a day, or their weekly alcohol intake because they don't drink all week, but then they binge drink on the weekends, that would be somebody that would be more of the alcohol predominant. This is a reminder, and as a person who does not drink, it is important for us to make sure that we have conversations with our patients and that we are representing the alcohol appropriately. So, for example, the bottom shows the alcohol content and then shows how many ounces of alcohol is in each. So, if you have a patient who drinks, let's say we'll go to this last one here. It's very different for you to say to your patient, how many liquor drinks of alcohol do you have in a day? And do you have a liquor drink or do you have a liquor drink? And I have learned how to explain to patients the difference between one shot of alcohol, which is 1.5 ounces, versus maybe 3 or 4 shots of alcohol that are inside that one glass. Very different to have a beer as far as the percent of alcohol comparatively to, let's say, a glass of somebody having a cordial liquor. So it's important for you to be aware of how much alcohol with how much percentage equals how many grams of alcohol that someone is drinking in a day, because someone drinking 1 glass of wine, but the glass is filled all the way up to the top. If it's a big glass, 2 of those glasses could be close to 1 bottle of wine in a day, versus the patient saying, oh, I just drink a glass of wine with dinner, and that may be a very different number for you. The difference with the pathogenic mechanisms in the dual etiology of patients who have not only metabolic associated disease, but also an alcohol component is that not only do we have the insulin resistance which does not cause lipid metabolism, etc., but from the alcohol component, we also have lipopolysaccharides and a microbe component because of the intestinal microbe from alcohol, which also leads to an inflammatory component. And then that inflammatory component will accelerate fibrosis and disease progression. So this is why the MetALD is a difficult patient to manage, especially if you're not really sure the amount of alcohol that's involved. I say this to my patients all the time when it comes to our KPA being lower in F1 versus moving towards F4. It could have taken 15 years for a patient to go from just steatosis to even early fibrosis of F1 or F2. But if a patient gets beyond F2, their progression that will move from F2 to F3 and F3 to F4 is usually significantly faster than how long it took the patient to get from just steatosis over to fibrosis. And this is the reason why we urge these patients so much to be able to change diet and lifestyle, make sure that their drinking is not substantial and losing weight, because we know the progression happens so rapidly once the patient already has advanced fibrosis. So we know we have patients who have steatosis, then steatohepatitis, which is the chronic inflammation, and then that leads to this says fibrosis, which ultimately it will be leading to fibrosis, which will then lead to cirrhosis. Yes, we have questions. Yes, we ask patients. We ask them to give us their honest answer for how much alcohol they're taking. But then we have other diagnostic measures that we use to get to the appropriate conclusion so that we know what our patients are telling us is truthful. FYI, about 30% of non-alcoholic fatty liver disease patients will have some alcohol consumption, which you or I, as well as the AASLD, will say is more than what they think is an average number. So we know, and we're very capable, and I've done other of my MASH network videos talking about how we diagnose and what we do to treat MASLD, metabolic-associated steatotic liver disease. All of those are right here. Patients who have elevated fasting glucose, elevated BMI, abdominal weight and abdominal obesity, high cholesterol, polycystic ovarian syndrome, etc. But in the patients who have a setting of alcohol use, which may be included in the assessment of metabolic associated and alcohol associated liver disease, sometimes people get very hung up on the things that are metabolic, and we forget to ask the questions like, how many drinks of alcohol do you have in a week? Do you have daily alcohol intake? That's a huge question for me. When I say patients, do you have any social alcohol? And they say occasionally. My next question is, do you drink alcohol daily? And then if they respond yes to daily, then I'm starting to quantify how many in a day. If they say not every day, but I see that it's kind of questionable, I will ask them to tell me specifically how many days in a week do you drink alcohol with dinner? Is it Tuesdays and Thursdays? Is it only on Fridays and the weekends? Our patient, who very clearly admitted to drinking 2 glasses of wine per night, her PEth test, which is our a blood test to check for chronic alcohol consumption and levels of alcohol consumption. This should be done on every patient who you're questioning how much alcohol they really drink. If their answer is anything other than, no, I do not socially drink alcohol, and her number is consistent with moderate to heavy alcohol consumption, which, based on her number of drinks in a day, I would say was not really a surprise to me. Her 2 glasses of alcohol every single day are probably larger glasses of alcohol and consistent with her number on her PEth test. So this is what's interesting, and what I try to downplay a little bit for patients, because people do not want to be accused of being an alcoholic. I will tell them that their PEth will be detectable for 3 to 12 days after a single binge. So if somebody recently was on vacation and they say that they just came back from vacation and they do not drink alcohol socially on a regular basis, I would probably discuss with them waiting to repeat this test until their follow-up visit to see if it is persistently positive. Versus the person who says to me, oh yeah, I only drink on Tuesdays and Thursdays. That person I would continue to order, because I want to see that their PEth test is consistent with a low number of amount of alcohol on the exposure, and not something that looks like it was a huge number. That would make me think that that person drinks much more than what they're admitting to. And this plot is to just show you that based on male, female, and somebody's weight, that there really was no difference between the mean number of units consumed per day. Excuse me. In patients with excessive weight, about 650 of them got screened. 617 of them got enrolled. People who were never a drinker or were missing were then excluded. For females and for males, the number is very different. Are 440 grams to 350 grams a week for women, and 210 to 420 grams per week, which equals a difference of about 20 grams per day for women and 30 grams per day for men. Their PEth number still had to be greater than 25. And out of these patients, 333 that were analyzed and weren't the drinkers, about 100 of them had both metabolic and alcohol-related liver disease. So it's an important question to ask because you want to make sure that you are appropriately treating your patients who may have metabolic disease but would then be excluded from certain medical therapies if their alcohol consumption was higher. So our patient has PCOS, hypertension, hyperlipidemia, and we know she's a little overweight. We know she has metabolic disease. But because she has an average of 2 glasses of wine per day and her PEth number was right in the middle of somebody who has heavier or moderate to alcohol use, I would say that she is somebody who has MetALD, metabolic and alcohol-related liver disease. When we talk about alcohol and it affecting the advanced fibrosis progression, but it also affects things like blood pressure, vasodilatation, weight retention in the abdomen, particularly in women. So these are things, and remember, Our Lady is already like in the stage 1 pre-hypertensive, despite being on medicine. These are all things that need to be addressed with patients, which are always a little bit of a taboo conversation. But when we are the providers who are going to be talking about patients with metabolic associated liver disease, you have to have these uncomfortable conversations. Similarly to the elevated blood pressure, look at the difference between alcohol and what it does to elevated triglycerides. Our water number is our brown graph, and then our blue graph are the patients who had ethanol. Look at the number of the fasting plasma triglyceride number in patients who hours after exposure versus people who had their numbers with no alcohol. There's a big difference, different than people drinking water. And then baseline numbers, triglycerides 6 hours after drinking versus the patients who were on water. So it's not just because we don't want patients to drink because we can't treat them with a certain medication. It's also alcohol is contributing to their metabolic factors. So in a closure, this is our case. This is Our Lady. She's 52. She's a Caucasian female. We know she has elevated risk factors for her having metabolic syndrome, but she also has elevated risk of MetALD because of her alcohol use. Based on her elastography and her CAP score, we know that she's got advanced fibrosis. So we are going to say that she has MASLD, which is our metabolic-associated steatotic liver disease, but I am not comfortable saying that she's not more metabolic than she is alcohol. So I would say that she is our MetALD, which is our metabolic and alcohol-related liver disease. Now, in this patient, if I was to tell her what her options were for treatment, I would tell her if she was to cease all alcohol, which based on AASLD guidelines with an F3 fibrosis, her alcohol consumption needs to be 0. Same for F2. If she was to decrease her alcohol to 0, which would probably make her lose weight, improve her hypertension, improve her high triglycerides, I would consider repeating her fibrosis evaluation in 6 to 12 months to see if it got better, because that may make her go down to a lower KPA and maybe be F2 or even a lower F3. If at that point She does not have the alcoholic related liver disease component to her equation, and she is just metabolic associated liver disease, then I would be considering talking to her about resmetirom. We are not currently prescribing resmetirom for patients who have MetALD. It's for patients who have metabolic associated steatotic liver disease. If she had said that she drinks alcohol occasionally or socially and her PEth number was in the lower frame, I would absolutely offer it to her. But when we are at moderate or heavy alcohol consumption use, it is not something that at this juncture I would give her. However, if she followed up in 3 months and says, I haven't drank in 3 months, and I have been losing weight, etc., and I repeated her PEth, and her PEth was non-detectable, less than 20, I would certainly consider it for her. As an F3 patient, regardless of the etiology of her fibrosis, she gets HCC screening. We are doing this for all of our patients, whether they are MetALD, MASLD, or alcohol. If we're going to talk about the clinical trials and the ideal MetALD definition, we need to make sure that we are paying attention to the underlying etiology of the patient's advanced liver disease. We have to talk about alcohol use. We have to talk about that getting a PEth test is something that we standard do on all patients who we're questioning whether or not they are giving us an honest, either quantitative or even a yes or no about alcohol use. And then make sure we're talking about things that alcohol also drives hypertension and elevated triglycerides, which then leads to further progression of their metabolic syndrome. And then making sure that we're clear about this. So, for example, if you have a patient that says 15 years ago, I used to drink alcohol daily, but I've been sober for 15 years, but that person has high blood pressure, central obesity, and pre-diabetes, that person is not somebody that I would consider as a MetALD. That's somebody I would consider with metabolic-associated steatotic liver disease. So we have to be very clear. My patient population of women who are usually drinking more than the average or acceptable guideline, which is 140 to 130 grams per week for women, 20 to 20 per day, 210 to 420 grams per week for men, about 30 a day, are usually people with not as many metabolic risk factors. In my patient population, the people who are more MetALD are more alcohol and less metabolic. But the alcohol consumption will further progress the metabolic risk factors. Make sure that you're getting a PEth test on patients if you're questioning whether or not they're being truthful about their use. Make sure that you're reassessing their metabolic dysfunction over time. So just like I mentioned with our case number 5, if she stopped drinking alcohol for 3 months and her alk phos goes down, her total bilirubin goes down, her PEth number goes down to a 12 or a 2, I would certainly consider her if she still had the PCOS, the hypertension, and the hyperlipidemia for somebody with metabolic associated steatotic liver disease. And then, of course, making sure that we are paying attention to all her socioeconomic factors, cultural realities, making sure that we're paying attention to the things that affect patients individually more than just putting them inside a bubble. If you have any other questions specifically about what we discussed today with MetALD, you can visit my specialty network personally through the GAP, MASLD, and MASH community network. Thanks, guys, so much. I hope you have a great rest of the day.